So we decided to go back on because our healthcare advocate wanted to provide some answers to some of the questions that we had had previously. And so we're doing that.
So I'm scheduled to testify this afternoon, and I realize that, I really could do it now. We have 15 minutes, or start now and continue later if there's a need. Or I could also just be available to sort of pick up the conversation that was just happening and give you my understanding of the dynamics. So one of those questions was sort of about the two different pools. It was recognized earlier that the individual market, we say has more acuity or is sicker or costs more. The average person in the individual market costs more than the average person in the small group. And so I am going to end up testifying like I would do this afternoon. I don't know how else to do it. In 2013, I think it was, when we put the pools together, we were doing that with the principle that a larger pool is a stronger pool, is a more stable pool, is a less volatile pool. I'll just say from a sort of a principled position, it's not like one person in the pool is paying for another person in the pool or segment of people in the pool. I've always objected to this concept that the small group is paying for the individual group. These are all just Vermonters who need care, and you can slice Vermonters apart in lots of different ways. You could slice them by age, you could slice them by gender, you could slice them by all kinds of things and find ways to describe one group paying for another group. Insurance is about spreading risk. That's why we have insurance, because if any one of us had to do it all on our own, well, lots of us could do it all well on our own because we don't have a lot of costs, but lots of us do have costs and couldn't possibly do it. So I object to the concept that the small group is paying for the individual group. But when the enhanced tax credits came along, and we got a look at just how valuable they were to the individual group, we thought, wow, the right way to structure is going to run counter to everything I just said. Given the rules from the feds, and the way that subsidies are defined in the individual group, it makes more sense for the benchmark plan, the silver plan that is how you define, how the feds define how much subsidy you get, to be more expensive. Because it is more expensive, it ends up having more subsidy. And so we ended up feeling like the individual group was really well protected with the enhanced subsidies, and it made sense to separate the markets for that reason.
So if I can just basically, because the federal enhanced tax credit was so great and it was based on the percent that someone could pay, it doesn't matter how high the cost is for your individual plan, you're never going to pay that.
More than 8.5% of your income if you're over 400% property.
So they were protected from that, and it provided us with the opportunity to then separate out the small group market so that employers who do not receive any enhanced federal tax credit would not bear the brunt of that combined pool, and their premiums would be, I hate to say that they go down, but they would be stable from having to the individual market bringing them up.
Yeah, and my recollection is at the time that the small group saved about $17 million. It's interesting to hear that today it's $23 million. That might be just sort of the inflation in the market. I need to understand that better. So here we find ourselves with the reality that the enhanced tax credits are likely to go away. We, of course, don't know, and we won't know until way too late. But my reading of the federal tea leaves is that it's very unlikely that this Congress and this federal administration, the Trump administration, are going to continue to support really what has made the Affordable Care Act, I'll say, Obamacare work. It's just hard for me to believe that there's any chance that they will continue. They, of course, could. But so I'm expecting that at the end of the calendar year, the enhanced tax credits will go away and we'll go back to existing law under the Affordable Care Act. And if prepared here with a presentation, if you go to page 27 of the marketplace report that DEVA supplied you, they do a great job of showing the premium tax credit levels under ARPA, under ARPA, and what they were under the Affordable Care Act. Let me just recognize, we all focus on the change over 400% of poverty. ARPA, or the enhanced tax credits, continued tax credits above 400% of poverty. And the loss of that is huge and real and will be painful for lots and lots of Vermonters. But ARPA also increased the subsidies under 400% of poverty. And if you look at that chart, you'll see that. So it will also be a loss for low-income people.
It will be what, Mike?
It will be a loss for low-income people. I mean, I'll just read one line, for instance. Under the Affordable Care Act, people at 150% of the federal poverty level had to pay 4.14% of their income on benchmarked against that silver plan. Under ARPA, it was 4%, a little over 4%. And I'm sorry, I just think I'm saying it wrong. Under the Affordable Care Act, it was 4%, and under ARPA, it was 0. So I just want to recognize that this will be hard for lower income people too. The cliff at 400% of poverty is huge. It's a disastrous cliff. It was a disastrous cliff, and it will be again. It will represent a dynamic where people will earn a couple dollars over 400% of poverty and lose. I'm projecting now as to what we think it will be, as much as $20,000 in tax credits. And I should say, let me clarify, family of four with all four people qualifying for the tax credits, as much as $20,000. I'll pause for a second and give you another detail. Because this is MAGI, this income is counted as modified adjusted gross income. There is some flexibility that people can do to mitigate, to reduce their countable income to qualify. But so there's only a little band there.
Can you explain that in English?
Yeah, so modified adjusted gross income counts, doesn't count contribution to a traditional IRA, for instance. And so if someone is a couple of dollars over the 400% of poverty, MAGI, they could reduce their countable income with a contribution to their IRA and put themselves below that number.
And get the subsidies.
And get the subsidies. So there's tools that people can do, and don't try this at home, folks. This is something you need help from a tax consultant and certainly from my office to help people do that. This is a basic tool that we help people for who are having to repay premium tax credits when they were paid too much, because there's limits on repayment, and same mechanism for people who are struggling to qualify for Medicaid. So I know I'm wandering all over the place. I kind of wanted to go. The punchline from the HCA is even even though we're really, really worried, this is going to be hard on all of us about losing the enhanced tax credits. And even though the enhanced tax credits were the justification of why we actually proposed to divide the markets. When we look at the lay of the land right now and the degree to which the small group is struggling, we agree that it makes sense to keep them separate. That's not easy for me. I have a whole career of trying to keep markets together, trying to build bigger and bigger markets. But again, given the lay of the land, we think it makes sense to keep them separate.
Lori, did you have a question?
Yeah, I guess I just want to make sure we're clear. So we're talking about the unmerged markets, right? And the reason for keeping them separate.
Right.
And at the same time, I want to be clear that this isn't helping anyone in regard, like this doesn't address the issue we have with the federal subsidies potentially going away.
Correct.
Okay, I want to make sure that they're separate things because I think that is a big
Yeah.
topic that
Yeah.
Vermonters need to understand.
Yep.
Okay, thanks.
Woody?
Are we working on state subsidies somewhere, someplace? I don't know.
Well, I think we should, though I also want to recognize a number that Addie said a few minutes ago, $65 million of increased federal subsidy due to the enhanced subsidies. That's going to be that's a challenging number to try and replicate. I realized I skipped over silver loading.
Well, we're still having you back.
Okay. Mm-hmm.
So you have,
Let me just give you a preview.
Okay.
Another dynamic that played out over the last, the Healthcare Advocates Office has been promoting it for about 4 years. It finally was put in place this year for the first time. And that was a new silver loading strategy, a new strategy to increase federal subsidies. And we saw New Mexico had done this, and then Texas had done it, and it looked like it really worked for them. And so we proposed to do it here in Vermont. And this past year, the Green Mountain Care Board, I'll say finally, they went a half step 2 years ago that we told them would not work. And guess what? It did not work. And they went the full step this past year to do the full silver loading. And I'll describe it once, and then you guys will all go, huh? And and we can talk in between, and then I can describe it again. I think it probably makes sense to do it a few times. So the first step in silver loading was when the first Trump administration stopped paying for the monies for cost sharing reduction, the subsidies that helped Vermonters with their low-income Vermonters with their out-of-pocket costs. All of this is in the individual market, by the way, not the small group. The strategy that many states did, and we did here in Vermont, was to take the cost of that subsidy and to load it onto the silver level in the exchange. And so we increased the cost of silver plans in the exchange. Silver level, that is the benchmark to define how much subsidy someone gets. And so for the person who got federal subsidy, federal premium tax credits already before the load, dollar for dollar, if they stayed in that same plan, and preface it a little bit, the subsidy was, the cost of the silver load was borne by the federal tax credit. So that was the first step. The second step, and that was done, well, during the first Trump administration, maybe 17, 18.
17.
Yep. The second step was in very much the same principle, to recognize the true value of the CSR, of the cost sharing reduction plans, and rate them appropriately. And so I'm sorry, this is going to be confusing to
I
people,
know.
but when you have a silver 94, you are buying a silver plan, but your income is low enough that the subsidy brings you up to a 94 actuarial value or a platinum plan, or even better than a platinum plan. And so the logic is, I know this is a silver 94, but it's really a platinum, and we should rate it for insurance purposes as a platinum plan. And so platinum plans cost more. And so we increased, so we counted people as if they were in platinum and therefore increased the subsidy, and therefore increased the cost of silver plans by about, I think, 40%. A really substantial increase in silver plans.
In the basic.
Yes.
Yeah.
Yes. And so that I know it's counterintuitive. Why is the healthcare advocate trying to raise costs of the silver plan? Because and this is where it gets tricky. People are going to have to shop, and we just had an open enrollment period. And guess what? I don't think they shopped as well as we hoped they would have. There's pros. There's some things that worked really well, and some things that maybe didn't work as well. But everybody who didn't get a subsidy had, everybody had an option to not buy a silver plan. Everybody who's not on a high cost sharing reduction plan had an option to go to buy a gold and carry the increased subsidy that they were getting because of the silver. So it worked. It worked really well. You saw the gold plans were less expensive than the silver plans. So you're getting a less expensive premium and lower cost sharing, and you're getting more dollars, federal subsidy dollars to do it. So it was an all around win. The Green Mountain Care Board actuary estimated that it was going to have about a $40 million value. It's not cash in people's pockets, it's increased buying power. So it's a little bit different. If you don't use any healthcare, it's a little bit hard to measure, but increased buying power. And so that's just another whole overlay of this whole thing. I think $40 million, I know I put it on a chart the other day, talking about how being proud of the healthcare advocates work. $40 million might be an overestimation. But without a doubt, the silver loading strategy is worth more to the individual market than it would be to recombine them. So that's a lot of my thinking about this.
You're going to tell us all about silver
Lots of
loading
things.
again in 3 hours.
Yes.
All right.
Can I ask
Oh,
a quick question?
Question.
So the cost sharing reduction was repealed in 2017. Was the purpose of this whole silver loading a result of trying not to punish the providers? So the cost sharing reduction didn't have anything to do with the providers themselves.
Let me restate. The funding for cost sharing reduction was ended by the Trump administration in 2017. The requirement that cost sharing reduction still be offered was not. So insurance companies were still told they had to do it. They just lost the money for it.
Gotcha, that's what I'm saying.
We backfilled it.
Okay.
It has an effect on providers because low income people have less out-of-pocket expenses that they can't pay. And so that's good for providers.
Mhm.
The justification, though, was, I'll say from my perspective, the justification was more consumer focused, making sure people had access to care.
Okay, because if the providers who are looking at these CSRs, right, would have just increased the amount of the premium itself because they weren't getting, I guess,
Providers who don't get out-of-pocket expenses have to that liability goes to the bottom line.
Okay.
Sure, but it's a bit of a different.
Yeah, I just was,
Thank you for letting me come speak for a minute. I don't know that I've made it more clear.
We'll have another opportunity.
The groundwork. But I did think that it made sense to hear it a few times, and you can ask me questions and we can.
Right. Thanks, Mike. Thank you, Mike. I think our next, are in the hallway. Do we want to go get, did somebody want to invite them in?
I will, because I have to. I'll be back.
All right. We'll just stand at ease for a moment without going back off of. We're still live. I just want to remind everyone, please.
I was in DC. I was trying to remember the name of the thing that the Trump administration took away, but I was in DC during that time to lobby. Make the insurance companies.
close to us?
This time I was
Hello, welcome. We are still live. Just to let everybody entering the room know.
Yeah, it was an interesting time to be side by side with the
analyst
insurance.
that started this whole. So we're gonna have to buy 1,000.
Good morning.
Morning, good morning.
Morning. So first time we've had you in, so welcome.
Thank you.
Really quickly, I know we did this for Diva. Do we want to just go around the room because DMH has not met some of us before, so Leslie, you want to start?
Leslie Goldman from Bells Falls area.
Good to see you. Mari Portis, Bristol area.
Dr. Powers, Waterford Environment right there.
Papa McFawn, I represent Barrytown and Williamstown.
Alyssa Black, and I represent Essex.
Daisy Rebecca and I represent Williamsky.
Wendy Critchlow, I represent Colchester.
Lee Page, Newport.
Alan DeMar, Montgomery and Enosburg.
Go ahead, Shannon.
Good morning. I'm Shannon Thompson, the Financial Director for the Department of Mental Health.
And good morning, for the record, Emily Hawes, Commissioner for the Department of Mental Health.
So we've got you in today talking about budget adjustment. And we will, just to level set for the committee, we will definitely have DMH back in to give their, sort of overview of what work they do. Can't wait to see the pyramid. But today we're just going to talk about budget adjustment.
Okay, great. We have been doing a system overview with the pyramid for a couple of other BAA testimonies. We can pass on that today and get right into the BAA if that works.
Oh, yeah, we can pass on that.
Okay, great.
No, I'm looking forward to the pyramid. That's
Yes,
what we said.
it's the big reveal, so we'll wait on that. All right, great. So with that, I'll pass it over to Shannon Thompson, our Finance Director.
So good morning. Can everybody see that okay?
Shannon, I don't think that's in our packet that you sent, is it?
It should be on page
Okay.
11 of the AHS.
What do we do? Just refresh?
It's posted 1 minute ago, sorry. Correct
Yeah,
myself.
so give us all a moment to sort of refresh and then we should see it.
Page 11.
So it's page 11 of the ups and downs.
Yes.
Gotcha.
Okay.
Well, that's a 27-page document. That we're in the right place. Most likely. Okay.
Right, there we go. Page 11.
Is everybody set? So the first item is $62,202 for Agency of Digital Service Level Agreement. This is it's the budget that is developed every year and given to AHS. And they in turn distribute the funding to the different departments based on the funding that's needed. This initial one is a redistribution of that funding to more appropriate levels per department. So it's not an increase. The second one for 129,772, that is an increase for those agreements, the service level agreements through Agency of Digital Services. Next, we have a transfer to Department of Children and Families for the Developmental Services Waiver Children. So this funding came over to the Department of Mental Health for our Integrating Family Services program for Northwest Counseling Services, Support Services, NCSS.
So this is just a transfer to another
This is a
department.
Transfer back.
Zeros out.
Yeah,
Yeah.
for those
Yep.
funds.
Okay.
Similar with the next one of $739,000. It's a transfer of the funding back to DCF for the Parent-Child Center. Questions on that? Net neutral transfers.
So they're transferring back to you.
We are transferring the funding back to them. They're going to hold the program.
Okay, got it. Can I just go back? I just want to clarify. So the ADS funds, they're split 50-50 between federal and general fund?
This is a combination of funding. It's one of those things that is distributed based on our commissioner level, basically, programs. So it's distributed across all of our fund sources.
Is it safe to say that it's a mixture of different funding lines?
Okay.
General fund, global fund.
Daisy?
Bear with me, but if I ask it now, then they won't ask it in appropriations. So under grants, the transfer to DCF, there are two. And they're global commitment funds.
They are.
Did we lose any federal dollars by not using that money?
We did use that money. This is simply moving the programs back to DCF that came over to DMH for Integrating Family Services, the IFS. So we use that funding.
It's just that DCF is gonna lead that program now. And it doesn't look like it used to look when it originally transferred over to us. So it's drawn down, it's an active program. But it makes the most sense to transition it back to DCF since they're the most involved in operating that program.
Got it. So those GCF dollars can still be utilized over there. They don't go away at the end of the fiscal year. And then I was going to ask a similar question about the federal authority line for those 1.1 million.
Oh, yeah.
Same thing.
That is simply because we need more federal authority. We have federal grants, more federal grants than we used to have. And so we need spending authority in order to be able to spend that funding.
And right now, when we go over that spending authority, we have to do a process. Do you want to name that process?
Yeah,
for
the
us?
excess receipts request.
And so this just takes that process away, so.
I'm not quite sure I understand. Can you explain federal authority?
Sure.
And what?
Yeah. Go ahead.
Let's,
So when we receive a federal grant, we have to compile all of the expenses under a federal fund source. And then we spend the money out using that federal fund source. And we have to have enough spending authority in our appropriation in order to compile those expenses. Otherwise, the system, the accounting system, the statewide accounting system won't even let us enter the expenses under that fund source. So we need federal authority in order to spend that money.
so this is not, you're not asking for more money. This is money that it's federal money. You're just asking for the authority to spend it.
Correct.
In the BAA.
Correct.
Okay, I think I get that.
So now we don't have to go through the excess receipts process.
I think you just answered my question, was who gives you the spending authority, but it sounds like it's us.
There are ways to get the spending authority. If we don't get it through the appropriations process, it's called the excess receipts request. That is a process that goes through the Agency of Human Services and Finance and Management. We have to justify the request. We have to talk about the grants that we've received, why we need the extra authority. So we're just doing that here in the BAA instead of going through that process.
Okay,
And then we will have it in our budget to spend.
thank you.
Did you have another question, Daisy?
I did, and it's about the same line item. Just process wise, does this mean that since we approved the budget, you all received a grant, which we have an approved spending authority on? Is this one grant?
No, I would say it's probably more than one. Yeah.
Okay.
But it was multiple grants that took us over our current authority for spending.
Okay, got it.
Yeah.
That helps me to tie in what the process is.
Yeah. And so that actually helps us when we get more federal grants, we can streamline our accounting process on our end.
When we do the budget, do we authorize sort of here's what we guess we'll get for grants and we authorize you to spend that? Or do we do it grant by grant by grant?
That's a really great question. There is a process called the AA1 process. So when we receive a federal grant, we still have to get permission from the Joint Fiscal Office to spend that money and to accept it. So there is a process to do that. And during the budget process, like for FY26, you'll see in the Vantage budget system a list of the grants that we currently know we have. Then things happen throughout the year, like with our block grant, we got extra COVID money, we got mitigation money from block grant. So we just sometimes we get or apply for extra funding that we don't necessarily know we're going to have at the beginning of the year.
Okay, great.
Anything else?
Are you gonna do the last line, the
Sure.
NMI?
The private non-medical institutions. Our commissioner will speak mostly on this, but DMH is expecting a budget pressure on this due to utilization and mix of placements in and out of state. So.
Sure. Yeah, I can take over. So two things are driving this. One is from the previous legislative session. Our state-run PNMI institutions now go through rate setting. And so there's an inflationary rate adjustment that's a part of this. The timing for that isn't necessarily on the same timeline as our legislative calendar. So there's an adjustment related to that inflationary increase. And then additionally, PNMI institutions are both in Vermont and out of state. And so youth who may be placed out of state, we have seen an increase of acuity in youth who have had longer stays at that level of care, which has driven that cost up.
Can you tell us briefly, what are our PNMIs?
Yeah.
What are we talking about here?
Yeah. So a PNMI is any of our youth residentials. It's a lower level care than, say, the psychiatric residential treatment facility, the PRTF that we talked about last year in the legislative session. So this is a lower level of care than that. But it's a residential. Youth stay there, receive wraparound services and treatment. There's nursing components. There's physician components, but not necessarily 24/7 like you would see in a hospital setting.
And we've seen an increase in utilization.
Increase in length of stay.
Stay.
Mhm.
Anyone have any questions about that? Okay, guess not.
We see that one every year, right?
I don't think so. Do we see PNMI every year? Last year we did because we were going through the rate setting conversation, but I don't recall the session before being in this context.
Yeah, I believe we'll see some increase, not like this, every year due to the new rate setting process, because there is an inflationary factor. So, and there are some other factors in the revised process that mean that cost is going to increase every year theoretically. It's still based on previous year's cost. So if a facility had lower costs one year, the inflationary increase might only bring it up to what it was the previous year, but you may see, I don't. I don't
And
know
is
what
it-
it's going.
Is it accurate to say that before the new rate setting process that went into play last year, was it a 5-year look back and then that rate was set, or how was that? Because we've changed how we do the rate setting for the PNMIs altogether.
Yeah, that's a good question. I believe it's the most current fiscal year end.
Now,
So it's likely 2 years prior
Yeah.
because it takes, time for the fiscal, for the year to close, for the audits to happen. And then our process, the budgetary process here is obviously way ahead of the actual spend year. So,
it's a previous to last year's work. It was a much more outdated approach. And so we're always playing catch up because we weren't necessarily evaluating the cost of delivering that care with current realities. What do you?
Yes. Did you tell us the age group and where these institutions are involved?
Sure. It's across the age span, but mostly adolescents utilize the PNMI structure the most. And so from a Vermont perspective, let's see, we have the School for Girls down in Bennington. Northeastern Family, NFI has, I think, 2 youth residentials in the Chittenden County area. That's about all I can rattle off at the top of my head. But we have a handful of PNMI institutions here in the state.
Numbers, how many are we treating?
Oh, we can get that information to you. Yeah.
It's not necessary, I'm just curious.
Yeah.
Since you're sending them out of the state, so
Yeah.
we must have a substantial number of them.
Yeah, I think it's whatever the definition of substantial is. I don't think it's hundreds of kids out of state, but I think there are a handful of kids who access the PNMI system in the state. And that's sometimes Massachusetts, and sometimes an out-of-state placement is going to have a program that maybe is better suited for that particular youth. So it's not always about what's available in state in that realm. It's also about what's the appropriate care for the youth.
We know just approximately, but is it half and half in-state, out-of-state, only a small percentage out-of-state?
There is a really nice report that actually breaks out in-state and out-of-state placements by county. And so why don't we work to get that over to you?
All right, that's great. Any other questions? Okay. Is that all you have?
That is all we have
that's it, the BAA.
for BAA.
That's it for BAA.
Are you gonna go over the governor's recommended?
Nope, we only have BAA for today.
All right,
So,
I'm sorry.
I just need a summary. So what you're not really asking for any more money. What are you asking for in like?
Yeah. I get it. Yeah.
Sorry.
Nope, that's okay. I think the ask related to more money sits in the PNMI line. And I think Shannon could point out, but is it the 2.1 million under the FY 25 BAA subtotal increases, decreases?
Yes, the total ask is 2,102,916. Of that,
Okay.
1.9 million is the PNMI
Okay,
and 1.1 million is federal
and
funding.
then it's offset by that transfer.
And the others
23 for general.
So we are looking at $2 million that you are asking above for the,
Correct, for the adjustments in the PNMI utilization and the inflationary rate increase.
So the triangle says you have 4 youth group homes that make up the PNMI system and 13 beds. That obviously is just for what's in state.
Mhm.
And that's the biggest, far and wide, the biggest amount contributing to the BAA ask today.
For the PNMI, yes.
For the PNMI amount. Do you know how much of that is going out of state?
I don't.
You don't,
Mm-mm.
and that's really the only line item we have to talk about today.
What do you?
I did get some information regarding mental health residential program. Where you are increasing the amount, I think originally it was 4 million. You're increasing it to 10 million, is that?
No, that line item is not a DMH line item.
Okay.
That lives with AHS.
Woody, thank you for reminding me, because we did have AHS in here and they indicated that you could talk about that. Am I remembering incorrectly? Anyone else in the committee?
Let me go look at their thing here.
Give us a moment here.
Yeah.
Sure.
Yeah, does Daisy want to ask a question in the meantime while I'm?
Yeah, it's right here.
A question for in the
Go ahead.
meantime, is
Yes.
about the transfer of the CDD from DCF to CDD, the funds for NCSS.
Yes. Yep.
I've heard great things about the work at NCSS, especially lately. Can you talk a little bit about why that's being transferred?
Sure. From our experience, it's more of a administrative transfer for that waiver of dollars. It's not necessarily a DMH program that we operate or facilitate. It's really Liz supporting youth with DS and DCF custody. And so our DCF friends do a really great job managing that program in collaboration with NCSS. And so that's it's more of an administrative shift as IFS has evolved over the years since 2000, I think 2014.
I think 2014 is when NCSS started.
Yeah, program, which was the bundled rate where all of the.
Is there has there been in the last couple of years, any difference in the amount of youth that you are transferring to DCF custody?
Not as it relates to the IFS bundle.
And I apologize, I was wrong about the 10, now that I've refreshed my memory. Sorry to put you on the
That's okay.
spot.
I was like, oh.
Any other questions for? All right, well,
Thank you.
thank you for coming in.
Thank you.
I think we can go off of, we are scheduled for, we're scheduled for a briefing at 11, which will not be live streamed. So I think we'll see everybody back here and we'll break until 11. And we can go